good evening or good afternoon, depending on which part of the country you are in. My name is Julie Green, and I am with Tactile Medical. We are very excited to bring you three fantastic therapists tonight to talk about prospective surveillance and the continuum of care for patients with breast cancer. Tonight, we are going to be highlighting Carrie Claiborne, Tara Newberry, as well as Kaylee Van Winkle. And all three of them have very, very different settings with which they work, and they have different experiences, and we are excited to share all of those with you. So this webinar is being recorded. Please submit your questions in the Q&A and not in the chat, and we will get started. We are going to play a short video right now.
So 2011 was the year of treatment, and of course completed by December 31st. But after that, it's like, now what? And I felt lost, kind of, just not knowing what to expect. My oncologist had gone ahead and mentioned lymphedema to me. It was described as being swelling. But I didn't have it. I went to a therapist because exercising and getting in a light workout with it was very important, and also regaining my range of motion because I had goals. I told the surgeon, I talked to the therapist that I went to see, that I want to be able to swim and I want to be able to golf again. Those were really important to me. And from there, maybe go ahead and exercise. Well, my bicep area started expanding. It wasn't hard right away or anything, but as it grew, it got tougher, more resistant, okay? So it's looser now because I have been on a lymphedema pump.
So after this video, we really wanted to bring forth information about how we can have more clinics, more hospital settings, more patients receive prospective surveillance. And so Sue obviously could have had more information and more education, and she did talk about that in a longer version of the video. But so tonight we're going to kick it off with Carrie Claiborne. She is a physical therapist and a CLT, and she's going to start talking about her experience and her setting. Thanks, Carrie.
Hello, I'm Carrie Claiborne. I work in Evansville, Indiana, in a hospital-based outpatient clinic. I specialize in oncology rehab and have been doing that for probably the past 8 or so years. Part of that interest kind of stemmed from just me personally wanting to know more how to help these patients, and part of that stemmed from my own personal information for myself, as I am a 16-year breast cancer survivor. So this is going to be just a short talk on breast cancer prehabilitation and rehabilitation next. So let's talk about the role of prehab in PT for breast cancer. Prehabilitation has been successful in reducing chronic long-term impairments, including shoulder dysfunction, lymphedema, pain, numbness, and tingling. It allows therapy to get baseline range of motion, postural and arm circumferential measurements. It allows education on postoperative lymphedema risk factors, and precautions can be provided. It also allows therapy to get baseline measurements on that patient's activity level, balance, gait, and overall function to improve quality of life and long-term outcomes. Next. So let's talk a little bit about prehab and integrating the prospective surveillance model. The link here is to an article by Stout et al. And it really sets the stage for why we need to be doing this prospective surveillance model. So in oncology rehab, prospective surveillance has been defined as a proactive approach to periodically examining patients and providing ongoing assessment during and after disease, often in the absence of impairment, in an effort to enable early detection of and intervention for physical impairments known to be associated with cancer treatment. Next. The goals of the prospective surveillance model is to promote surveillance for common physical impairments and functional limitations associated with breast cancer treatment. It's to provide education, to reduce risk or prevent adverse events, and facilitate early identification of physical impairments and functional limitations. To introduce rehabilitation and exercise interventions when physical impairments are identified, and to promote and support physical activity, exercise, and weight management behaviors through the journey of disease treatment and survivorship. Next. So in that Stout article, this is a perfect chart to kind of explain how this prospective surveillance model can work. So on the left, you'll see, we're seeing patients prior to surgery, right after diagnosis. We're calling this our prehab visit. At this visit, we are getting baseline objective measurements. It can be range of motion, strength, activity level, tolerance, pain, fatigue, function, weight. We are promoting health skills and behaviors. We're talking about what to expect with surgery, what exercises you can be doing after surgery. And then we move into the post-operative phase where we're bringing the patient back in. Again, we are looking at those same objective measurements that we did at the prehab visit. And then again, we're looking at promoting that healthy function and behavior. At this time, we're also incorporating more details in the exercise role. There's so much research out there that supports that patients should be doing about 150 minutes of exercise in a week, and that's a minimum. So if you break that down, 30 minutes, 5 times a week, and then twice a week of resistance training. So this is really a time where you can start integrating that exercise model for these patients and help guiding them. It could be starting with 10 minutes and then moving from there. And then this also allows us, when we can start identifying if there's any impairments, and if those are detected, go ahead and initiating that rehab program. If they're not detected, then we're going to continue on into that surveillance model, which is on the far right. In this model, we are bringing them back periodically. We're looking at those same objective measurements, and then we're also continuing to promote activities, function, exercise, and just a healthy model of living. Next. So this is our protocol that we developed. I work for Progressive Health. This protocol, we kind of took the foundation from ImpediMed that does SOZO. They had given their recommendations for the SOZO machine, which I'm getting ready to talk about in a little bit. So we knew what they wanted for the SOZO protocol. We adjusted it. We took into consideration additional therapists that I work with, physician input, surgeon input, patient input. Of course, when we're dealing with insurance, that plays a role too in looking at visits and all of that. So we see patients prior to surgery or chemotherapy for those baseline measurements. Those measurements could include the SOZO machine, range of motion, strength, circumferential measurements, posture assessment, their current activity level. Functional tests are typically the tug, 4-stage balance test, a 30-second sit-to-stand test, and grip strength. We have the patients fill out baseline outcome tools, which would be Quick Dash and FACT-G. Patients are typically returning about 3 to 4 weeks post-op. If they're having neoadjuvant chemo, then we may follow up in a couple months, or as needed if sign or symptoms start. At that 3-week post-op visit, we're comparing the baseline preoperative measurements to their current condition, in addition to assessing for postoperative concerns that will benefit from skilled care. And then we reassess every 3 months for the first year if it's indicated. If it's not indicated, we're not going to have the patients come back. Additional therapy visits may be added if impairments are found. Next. At this prehab appointment, patients are also receiving information about what to expect with surgery, circulation exercises, general range of motion exercises to begin 3 weeks postoperatively. We are keeping in mind if they have drain tubes, then we are making adjustments with that, as well as if they've had reconstructions, and we're following the guidelines of plastic surgeons. Examples of exercises patients may receive would be cane flexion, cane abduction, chicken wings, wall walks, scapular retraction, shoulder rolls. We provide a lot of different information on services in our community and resources. It could be mental health, it could be support groups, it could be exercise classes slated towards cancer survivors. We provide information on places for bras or prosthesis. Knitted knockers is an example of something that's on there that patients can get for free, which is a nice interim if they are waiting to be fit for a bra or prosthesis. And then information on places to order compression garments if that's needed. Next. So let's talk about the SOZO machine. The SOZO machine was a huge, huge part of really launching our prehab program. We had everything set, but then once we got this really helped to get the physicians, the surgeons on board. It definitely integrates the prospective surveillance model. So it is a digital health platform. It's non-invasive, fast, it's easy to use. It takes about 30 seconds to run the scan. It tests patients at risk for lymphedema by measuring their bioimpedance. The ImpediMed recommendations are that you should scan patients every 3 months for the first 1 to 3 years, every 6 months, the first 4 to 5 years, and then check annually once they are 6 years out. The goal of SOZO is to test, trigger, and treat before lymphedema becomes chronic. Next. So what is bioimpedance? This is what it is measuring. It's a bioelectrical impedance analysis is a method for estimating body composition, in particular body fat and muscle mass, where a weak electrical current flows through the body and the voltage is measured in order to calculate impedance of the body. Most body water is stored in muscle. Therefore, if a person is more muscular, there's a high chance that the person will also have more body water, which leads to lower impedance. A lower frequency and a high frequency current passes through the fluid, fat, muscle, and bone. This is what is being measured with the SOZO machine. Next. So the SOZO is unique because it gives you an LDEX score, which is, it takes the measurement of each limb and it calculates it with a ratio of the healthy limb to the at-risk limb. And as the fluid increases, the impedance is reduced and it increases this ratio. This ratio is converted to a score. This score is only available through ImpediMed, and it detects lymphedema-related fluid changes in limbs. It detects it at its earliest subclinical stage, and this early detection with intervention helps to reduce progression to chronic lymphedema. It is so specific, it can detect fluid changes as small as 2.4 tablespoons of fluid. What you are looking for is once you establish that baseline, you're looking for a change of 6.5 from that, which would indicate stage 0 lymphedema. And the picture that is shown, if we're in green, we're good. If it goes into the yellow or red, that's when we're starting to get those changes of over 6.5 and seeing those detections. Next. So what happens if SOZO triggers? If it goes into that yellow-red, it is indicated to get a compression garment for the upper extremity and wear for 1 month and then retest. And this is according to ImpediMed and the research that they have done. So if the measurements return to green after wearing for 1 month, then it is recommended to use the compression garment as needed. There's really no guidelines there. It's really based upon how the patient's doing, subjective and then clinical reasoning by the therapist. Because the SOZO does not identify truncal or breast swelling, if that is occurring, then we're usually identifying that with our clinical judgment, ordering compression bras, tanks, and also maybe placing a referral to Tactile for that pneumatic pump. Even though the SOZO does not give us any information on when we should place that order for the pump, if the patient is triggering, then I am usually going ahead and placing that order to Tactile then to get the process going, because I feel like the pump is one of the best options for long-term management. Next. So this kind of ties in about the role of that pump and why that's beneficial for proactive. So the NCCN guidelines call for that proactive intervention. Early detection and diagnosis is key for optimal lymphedema management. We want to identify patients in stages 0 and 1, which are more responsive to management before it becomes chronic. As a provider, we should be educating and making recommendations to the survivor. That should include the importance of recognizing and reporting signs, symptoms, or infections to the healthcare team, giving them guidance on physical activity and supervised resistance training to help improve symptoms, and then considering the compression garments, manual lymphatic drainage, and then placing that referral for the pneumatic compression or the Tactile FlexiTouch pump. Next. So what are some of the challenges with SOZO? As of right now, it is still contraindicated for a patient with a pacemaker or defibrillator, or if a patient cannot turn off a pain stimulator. I have found it personally challenging if a patient has tremors or they have tone that limits their weight bearing through that extremity, even in a sitting position. You're just not able to get good contact with the electrical aspect of it. I found it works best if both the machine and the patient's feet and hands are wiped down with baby wipes. And I think the biggest hang up is it does not measure breast or truncal swelling. So we still need to use our clinical judgment for that. And that's the case, then we're still taking our circumferential measurements around the breast, above breast, umbilicus, depending on what we're treating. Next. So what are the successes of prehab that we've seen? Being proactive and addressing concerns as they happen, helping to reduce chronic issues, improving quality of life. We've been doing this prehab program for 3 years with the SOZO. Patient feedback has been very positive. The biggest thing we were hearing from patients is, why hadn't someone sent me to therapy sooner? Why couldn't something be done? And I think we're getting a lot less of that because we are catching things sooner. And then certainly we see it help reduce the amount of therapy visits, especially for not wrapping people, reducing, and it helps with reducing therapist burnout too, because we're able to just be so much more proactive. I think some of the biggest holdups is just physician buy-in. They don't really understand, why do we need to be doing something when something's not wrong yet? That's more visits. Is that going to stress patients out? For the most part, I don't think so, but obviously I'm an advocate. I think physicians just understanding the role of physical therapy in that clinical care, as well as physicians understanding why the patient should be seen even if they're not having lymph nodes removed. This has been a big one that continues to come up because they're looking at it only from a lymphedema risk. We're looking at it as like, well, what about hoarding? What about decreased range of motion? What about fatigue? What about neuropathy? What about all the other things we can help aside from just lymphedema? Next. So I just wanted to touch base on physical medicine and rehab and just the role of the support system in a prehab program. So we are fortunate to have a close relationship with our PM&R doctor. She has really worked with us over the past 5 years on establishing and improving oncology. We are able to see patients together during multidisciplinary breast clinic to speak on the role of our services and how they complement each other. She oversees the side effects from chemotherapy and treatments, could be the neuropathy, the bone health because of endocrine therapy, fatigue, nutrition, social services. She can refer where she needs. She refers to us to help address the side effects proactively to help improve patient function and quality of life. And then we refer patients to her as well. If we are seeing patients, they're developing side effects and they're really just needing a physician overseeing them and helping them manage. They're not sure who to talk to because there's so many on their team as they're going through it. Next. If you don't have a PM&R physician, we recommend being present for oncology committee meetings, breast leadership meetings, setting up marketing meetings with your referring providers for them to better understand therapist role. Reach out and work closely with the support staff, with the nurse navigators, social work, community resources, other members of the team. And that's really how ours started, was just making those contacts and being persistent about the services and how we can help. And then if you're able to be present in multidisciplinary meetings, it's such a good learning resource, but then you're also there with all of your referral source. You're able to bounce ideas off. You're able to just learn. And so that's kind of why, part of the reason I do what I do. One thing to leave with for my final note is, patients always say they're so fortunate for the team of doctors saving their lives, but what about their quality of life after? And so that's what I'm here to do, is to improve that quality life. Thank you.
Thank you so much, Carrie. That was fantastic. I appreciate all of the insight about SOZO. I don't think that a lot of clinicians really know very much about SOZO and how it can really improve the outcomes and care of your patients. And also just really the interdisciplinary approach that you have with your entire system. Thank you so much. So now we're going to move on to Kaylee Van Winkle, and she's going to talk a little bit more about going beyond patient care.
Okay, thank you. So I imagine for the vast majority of us listening tonight that patient care is our passion. But if we're really going to establish a prospective surveillance program, we need to really take the time and go beyond patient care and get involved. So what that means is, I've been at a hospital-based outpatient rehab for almost 10 years, and our hospital is accredited by the Commission on Cancer. To maintain our accreditation, we have a cancer committee to set goals and expectations for the hospital, and really the improvement of cancer care for survivors. And so this committee is comprised of our medical oncologist, our surgical oncologist, radiation oncologists, oncology nurse navigators, oncology rehab, and that's where I come in, and then many others. So we have to be willing to speak up in these meetings to let our providers know how oncology rehab can help, and volunteer with setting hospital program goals and offer assistance with data tracking. We need to be able to speak up at some of these tumor boards to mention, hey, it looks like this patient might benefit from oncology rehab based off of some of their treatments. Do you think, what do you think? Or even, this chemotherapy medication is known to contribute to possible chemo-induced peripheral neuropathy. Are you seeing any of those? Are you seeing them exhibit any balance deficits? And just to be the bug in their ear of what might be going on, and how we can continue to help and partner with them. Our cancer committee has a subgroup called our survivorship committee, and this is our oncology nurse navigator, our oncology cancer coordinator, oncology rehab, and a few others. And so I sit on that committee as well, and we do a lot of outreach to help with, patient education. This coming weekend, I'll be doing an educational talk about early treatment for lymphedema and how we can help. And being willing to volunteer for those types of events is helpful, because we can get patients on board with early intervention, and maybe they weren't fortunate enough to have that, but chances are, somebody they know will be diagnosed at some point with cancer. And so having gone to some of these educational events, they can say, oh, I know that, that could have helped me. Maybe it could help you. And so, our cancer survivors, it's such a community that they do want to help each other. And we want to be there to help to educate them in any way that we can. Going to the marketing meetings. I don't know about you, but I'd rather have a dental procedure than go to marketing. But these marketing meetings can be so helpful, not just, to meet our referring providers, but also their support staff. Their nurse practitioners, their PAs, their even their medical assistants, they have a part too in seeing this patient and talking to the provider as well if they start seeing some functional limitations or any issues with the patient, as the patient is talking with them when they're going into these meetings to say, oh, maybe that patient could also benefit from physical therapy or occupational therapy, any kind of oncology rehab. We know that it's a critical part of survivorship. I mean, if you're on this call, you know that early intervention and oncology rehab is essential, but we have to be involved to help other people know that too. Next slide. I had a beautiful opportunity about 5 or 6 years ago at our hospital. We got a brand new breast nurse navigator, and we were talking, and she was really excited about oncology rehab, but she told me that she was nervous about making the recommendation because a lot of these patients would ask her, well, what are they going to do to me? And she said, honestly, I don't know. And so from that conversation, I just invited her to join me for some patient evaluations. And that way she could see firsthand exactly what we might do to these patients. And while it's a big undertaking to have somebody join you, I had her join me for 3 evaluations in a day. And it was the most perfect example, I couldn't have set it up better. The first patient was a newly diagnosed breast cancer survivor. She had just had surgery. And so she was having some limitations like shoulder range of motion, weakness. And of course, we wanted to look at, early lymphedema screening and prevention for lymphedema, which was really important. And her goal, that patient's goal, was that she was in such pain and her arms were so weak, she couldn't even hug people. And she's a hugger, so she wanted to be able to do that. And so from there, I was able to discuss with that nurse navigator how early screening could have helped this patient in that, she needed to be able to have radiation. So she was coming to me pretty early after surgery, and she needed to be able to have her arm in a, flexed and abducted position to be able to have her radiation. And had we been doing early treatment, we could have been able to give her exercises beforehand, but then also do some lymphedema screening ahead of time as well. The second patient was actually a woman who had been diagnosed with breast cancer and completed all of her treatments about 3 to 4 years prior. And so she was familiar to me, as I knew that, lymphedema is not curable. So, she was having a flare up at that time. And so the nurse navigator really got to see what it looked like for chronic lymphedema, but also somebody who had been getting treatment. She didn't have the typical, elephantitis that you might expect from chronic lymphedema. But she did have those deficits that were clear. And so she didn't want it to turn into that, which none of us do. And so that was another really great learning opportunity for that nurse navigator. And the third patient was actually a sweet woman who had stage 4 breast cancer with metastasis to her lung and her bone. And she was having a lot of functional limitations, like just weakness and deconditioning from her chemotherapy treatments, pain. She was limited to a wheelchair. And her goal was that she wanted to be able to walk without always needing the help of her family. She, even just short distances within her home, she wanted to be able to move around on her own and not continue to just get weaker. And so being able to care for these patients across the entire cancer continuum, from the time they're diagnosed through radiation, chemotherapy, and surgery, this was a great time to be able to demonstrate to our nurse navigator how cancer rehab could help. And so I'd encourage anyone listening to invite their nurse navigator or any provider that's interested in oncology rehab to observe what we're doing and how we can help these patients. While we're treating the patient, we need to be aware of their potential chemotherapy side effects and screen them for lymphedema that can be caused, or from, chemo-induced peripheral neuropathy, and look at what their balance looks like, look at what their mobility looks like. And with surgical recovery, a lot of our prehab patients that I'm getting have had have completed their neoadjuvant chemotherapy and may have side effects from that, or during that time they were able to even educate themselves or go to some of those outreach programs and advocate for themselves to get prehab treatments, so that way they could get measurements, but then also work towards that program. And then coming back to therapy for post-recovery, being able to regain that shoulder range of motion, address any axillary cording or lymphedema side effects, and improve their mobility as well. Being aware of the radiation side effects of fatigue and skin sensitivity, lymphatic complications involved with that. Being able to surveil them over, the next 1 to 2 years, not, keeping them in therapy for all of that long, but, having them come in, I'll tell them to come in for their 1-year checkup and make sure that everything's on track. And then, knowing that we can still help them even through advanced cancer care, that it's, they don't have to just accept having reduced mobility and a decreased quality of life. Next slide. So a lot of my colleagues will ask, how do you organize their plan of care when patients can fluctuate? And, for a typical orthopedic patient, coming in, you would expect to maybe see them 1 to 2 times a week. And then as they progress on, their frequency should decrease, and they don't anticipate seeing patients beyond, 12 weeks. But the oncology patient is very complex, and it's not going to be as straightforward as that. So, a lot of their plan of care is going to depend on where they are in their cancer journey. And we need to be willing to be flexible with that, to adjust their frequency based off of their treatments and what they're going to be having done. A lot of times I might see somebody early after surgery that needs to have radiation, but they need to regain their shoulder range of motion. So our plan of care might be a little bit higher in that frequency, 2 to 3 times a week. And then once they start radiation, reducing that frequency, even knowing that cancer-related fatigue is going to kick in, and also skin sensitivity is going to kick in. So reducing that frequency to maybe, every other week or even once a month, depending on how long that radiation care might be. But if they started developing symptoms, still having that close relationship, that you can increase that plan of care again, so that you can address any symptoms that might be coming up while they're getting those treatments. That way, the patient also feels really comfortable with you, knowing that they're still being watched and taken care of, and that they don't feel like they have to try and continue to advocate for themselves if they start noticing any side effects. They can go to you and say, "Oh, I feel like my arm is heavy. Can we check it out?" And we will believe them and be ready to take care of them. All right, next slide. So, when we have these patients and we're taking care of them through their entire continuum, we need to prioritize what we're going to do with them. And education is so important for these patients. If we're going to have the privilege of walking through with them through their entire course of care, of treatment, it's such an opportunity to educate them and help them to know what's going to come next, but also trying to do that in a way that doesn't promote fear or anxiety. It's such a comfort to be able to have someone that is knowledgeable, that knows what's happening, and that can direct you and prepare you for these treatments, but also to say, okay, if some of these side effects are going to come up, this is how we mitigate it, or this is what we're going to do to manage it. And we can go ahead and take care of them. It provides a lot of ease to know that they're not alone during this time. Also, depending on where they are, we're going to consider compression garments, having those compression garments early so that we can contain them before they start developing any swelling. And a lot of that can depend on their risk, but then also what treatments they're going to be having, which relates to their risk. We're going to regain any shoulder range of motion limitations. We're going to regain their strength, their functional mobility. If they have axillary cording, we're going to address that, addressing pain. We're going to do manual lymphatic drainage to help to support the lymphatic system. A lot of these patients will have post-surgical swelling that you would anticipate, but we also want to make sure that we can help manage that, because letting that post-surgical swelling sit there for a prolonged period can be detrimental to them. And ordering a pneumatic compression pump if they need it, because it is a really excellent tool in your toolbox to be able to help these patients, especially with long-term independent management. And keeping in mind their goals, every time going back to their goals, so that when they leave you, they can be able to give you that hug because you helped them achieve their goals, or they watch them walk out of your clinic and leave their wheelchair behind. Is such a rewarding feeling. Thank you so much.
Thank you, Kaylee. That was fantastic. And a couple things that really struck me was the fact that you were willing and wanting to go outside of your comfort zone. because I know that most therapists, that is not an easy thing to do, to go and try and market a program to maybe physicians and coordinators that aren't all that interested in taking on extra work. So I think that's fantastic. Also, volunteering your time and making sure the patients don't feel afraid, because that often really is a roadblock as well. When you have a patient that is a little bit anxious and afraid, I think that really empowers patients when you provide some education. So thank you. And that's a perfect segue to our next speaker, who is Tara Newberry, because her persistence really paid off in the program that she started at her facility.
Hello, my name is Tara Newberry. I am the Oncology Rehabilitation Coordinator at Carilion Clinic. We are a mid-sized hospital system in the southwestern portion of Virginia. We cover hospitals, acute care, home health, outpatient, and even wellness centers with our oncology rehab program. Next slide. So at Carilion, our program vision is really to provide a comprehensive and compassionate rehabilitation program to increase the patient's quality of life wherever they may be on that cancer journey. So it can be all the way from diagnosis throughout treatment into survivorship and even into hospice when needed. Next slide. So there really are some scary statistics when we look at breast cancer and its prevalence. So literally 1 in 8 women will be diagnosed with breast cancer in their lifetime. And that means if we as clinicians in the role and the time period we are now don't change the way that we treat these terrible side effects and be more proactive, that we as a group are going to be dealing with these same issues. And it's important that we take care of, this healthcare crisis and we make the changes we can now. It's great that the 10-year survival rate for non-metastatic breast cancer is 85%, but that does mean that women are living with, up to 70% of women are living with lifelong incurable lymphedema, range of motion impairments, tightness, pain, and just decreased overall function. So I really do think that we have a responsibility to change that now in the rehab community. Next slide. So what makes our oncology rehab program successful is literally our teamwork and how we surround the patient. The patient is at the center of that care. They're at the forefront, and we have made a significant impact with rehab entering tumor boards and breast cancer conferences and really being a part of that team decision versus this ancillary thought later. So actually having a real-time conversation when that surgeon presents that breast cancer case, or a real-time conversation when that medical oncologist presents what chemo they're going to do, or the radiation oncologist talks about where they're going to do radiation. And so I'm able to tell them at tumor board how rehab can actually intervene before the patient even starts treatment to help them, educate them, and become a better stewards of their health care and better empowerment of their health care throughout their treatment. And then also having that post-treatment support of therapy and into survivorship when needed. Next slide. So the breast cancer therapy screen we use before we go to tumor board, we get a list of all the patients that are going to be presented, and I do chart review on the at-risk list. And this at-risk list includes things like axillary node dissections, if they're going to have radiation to regional lymph nodes, anyone who's having a mastectomy over the age of 60, if they have a BMI over 25, African American and Latin descent, or multiple comorbidities that may affect fluid retention, like congestive heart failure, chronic kidney disease, or diabetes, or other autoimmune disorders. And then, of course, a previous history of breast cancer with treatment. Sometimes it may have been on the same side, sometimes it may be on the opposite side, but we know those women are already going to have more scar tissue and more lymphatic stagnation than someone who had not had those issues. And then sometimes patients don't meet the at-risk list symptoms, but they may already be showing some symptoms as far as existing edema and swelling, or existing pain and stiffness and range of motion, or a new onsets of aches, tingling, and numbness. So it really depends on presentation also. It's not just that black and white in the chart. So really try to be comprehensive with having a real conversation about what's going on with that patient as soon as they are diagnosed. Next slide. So our clinical pathway with this is we're starting at tumor board, we're screening for those therapy needs, and then we're also determining whether that person would be a good fit for home health or outpatient. The 85-year-old who already has mobility problems and who is on a walker or needs assistance with mobility, she may be better served in home health. And if it's the 35-year-old who's still working and active, she would be, of course, better served in outpatient. But no matter where they are, they're still getting that comprehensive prehab education with those baseline measurements. And we're really doing a holistic, comprehensive evaluation, which we'll talk about a little later. Then when they do go on to surgery, we do have acute care therapists who are certified lymphedema therapists and oncology certified therapists that can go in and provide education and give the patient a little bit better idea of what to expect going forward with a touch point. Then we're able to take them into the home health setting if needed. They're not able not only to get a lymphedema therapist who would be an OT or PT clinician, but they can also get general OT or PT depending on their strength and endurance needs, their ADL needs, and then also skilled nursing to come in with wound care needs or help with education management and medication. Just able to give that person, that immediate post-surgery support. And then this is a big thing with our program. We do continue to treat throughout radiation and chemo because we believe that it's important to be in there during the remodeling process. We're not going over any reddened skin or in that radiated field, but you can definitely drain and work the skin above and below it. You can still do range of motion, you can still do some stretching, and you can still help keep that patient more detoxed and ability to be able to withstand those treatments better. We've been able to see a more well patient can withstand those prescribed doses of chemo and prescribed doses of radiation. So then we can take them on to our outpatient setting where they can also still get, of course, that lymphedema therapy from the OT or PT clinician and general OT and PT to really focus on that exercise and that decreasing cancer-related fatigue and things of that nature. And then we really try to promote overall survivorship and wellness past us, getting them into a maintenance program, getting them, the Flexi Touch, their compression garments, and getting them a good exercise program that fits their lifestyle and they can continue on because now we know that exercise actually fights cancer itself, and then it actually can help with decreasing inflammation and therefore decreasing the chance for recurrence and things of that nature. And then, of course, we follow the surveillance model, and we go along with what their surgical or medical oncology appointments are, so they're always checked on at later checkpoints. Next slide. So what we found is we were able to do our own study surrounding prehab. And what we found, we had the goal for NAPBC accreditation, which is the National Accrediting Program for Breast Centers. And our goal was just to increase the number of prehab referrals. Well, we did that. We did that from 2021 to 2022, and we found that the surgeon and the medical oncologist found that patients were having better outcomes, and so it was all positive. But when I was actually digging into the chart, I found something even more amazing. I found that the women who were met that at risk for impairment, who had a prehab appointment, their average number of visits per episode of care for therapy was 7.7. And the average number of post-surgery therapy visits for a woman who did not have that prehab appointment and met that at-risk list was 19.2. So if they did not have prehab and they were still at that risk list, then they had almost 3 times as many appointments. So to talk about symptom burden, decreased outcomes, and increased healthcare costs, I think it's very important that we are presenting this information to our leadership so we can show the true validity of prehab appointments. Next slide. So what do we do for assessments for breast cancer? The important thing and takeaway here is that it's very holistic and comprehensive of the whole body. Not only are we doing baseline circumferential measurements in bilateral extremities with palm, wrist, and then plus 10, 20, 30, 40. We're also doing chest measurements at nipple level if possible, or just find a bony landmark to measure from so that everyone is on the same page. And those therapists from home health to outpatient and even into wellness or surveillance program can see if there's an increase. Unfortunately, we're not lucky enough to have the SOZO. But I do think it's very important that we take standardized measurements so we can really measure that patient's progress or regression. And then we also add in the umbilicus and then plus 10 centimeters or minus 10 centimeters, or sometimes depending on the torso size, it's sometimes +5 and -5. But we also measure for strength and endurance, mobility, range of motion, do neuropathy screen, quality of life, even cognitive questions due to chemo brain and wanting to get a baseline there. Okay, next slide. So, of course, we're looking at lymphatic malformations and stagnant fluid with our patients. And so this, I think, is a good illustration of what that looks like under the skin and what you're trying to even out, reroute, and regenerate healthy fluid routes with the lymphatic vessels. But go to next slide. It's also crucial that we look at what's happening under the skin with the fascial system and scar tissue. So if we're not working all systems of the body, if we're just staying superficial and we're just working that lymphatic system, I don't think we're truly making an impact on what is really going on in the deeper level, and can we really make a difference if we're just working in that superficial level when the damage often goes much deeper. Next slide. And so what we do to be able to address that, we're a very manual, hands-on clinic. We do lots of different types of massage and use different tools such as vibration and wash-on and cupping, even throwing in some myofascial release for stretching and cording and things of that nature. Of course, we're talking to the patient about compression. Of course, we do manual lymphatic drainage. We do lots of stretching techniques and teaching the patient stretching techniques, even adding those myofascial strokes during the stretching techniques. And then, of course, throwing in things like kinesiotape and a specialized exercise program. But we also want the patient to be very proactive and be in control of their own maintenance therapy. So giving them the tools such as the Flexi Touch and the compression garments, and teaching them how to do massage, and giving them tools such as a vibration tool, showing them those things, showing them how to self-kinesiotape is very important because they can't have us forever. They don't have an unlimited number of therapy visits, and we all know there aren't an unlimited number of lymphedema therapists to see these patients forever. Okay, next slide. Surveillance, like I said before, we follow along with what the physicians normally do. So the first 2 to 3 years, they're performed about every 3 months. And then we go to years 3 through 5, and they go up to 6 to 12 months, and then more than 5 years. Those are performed annually. But we always have our providers looking for any kind of edema, swelling, heaviness, fullness, and that includes not only the arms, but the chest, the breast, the back, the abdomen, and even the lower body, because we know certain chemotherapies are really bad for causing lower body edema also. We also don't want that patient to have to go through pain. We don't want that stiffness or limited range of motion. Getting cancer is bad enough without having to live with the long-term terrible side effects after cancer treatments. And then constantly talking to the patient about their strength and endurance and fatigue level and trying to keep them as healthy and as motivated as possible. Next slide. So I think we as therapists are amazing individuals, and this speaks to me more than anything when I think of lymphedema therapist, because we do work with our hands, we do work with our brain, but we work with our heart also. So just take this into consideration when you're working, that a man who works with his hands is a laborer, a man who works with his hands and his brain is a craftsman, but a man who works with his hands, his brain, and his heart is truly an artist. So you are wonderful artists, and thank you for everything you do every day for our patients.
What I wanted to say about Tara is because I've had the pleasure of working with Tara in the past and had her present at another program, is that, and I think that Carrie said it in the beginning, everyone here is really invested in prospective surveillance. And I think a lot of the challenges sometimes are getting the buy-in from our providers and from all of our colleagues that work in the actual cancer center. They're always very invested in, getting the patient through the cancer journey, but they sometimes forget that the surveillance and the survivorship is as important and impactful to the patient. We have a ton of questions, and so I think I'm just going to go right into some of the questions if you don't mind. But thank you so much, Tara, and you have fantastic information. Thank you for your persistence in your program and developing it. And I think hers is a little bit unique, and maybe I'm wrong, but the fact that she has all the way a connection all the way through to home care, and so she's had a big part in developing all of that. So congratulations to you. So I'm going to start with some of the questions around SOZO. Because as I said, I know that this is not something that everyone has in their clinic, and there are some challenges with it, right? So one of the questions is, does it account for weight gain? What scores differentiate it for stages of lymphedema? And I don't know if you know, Carrie, if you
It
could
does
answer that.
account for weight gain. You weigh the patient every time you scan them. So we have a scale next to that patient. They take their weight and you enter their weight. And then that makes that adjustments, because certainly we have patients that may be gaining weight as they're going through chemo with steroid treatments. They may be losing weight. They may have nutritional changes. So that weight is taken each time that you are scanning the patient. As far as what stages, like it mentioned in my slide, the change of 6.5 is accounting for stage 0. So that's probably going to put you right at that green to yellow marker. So certainly from there, I don't have any criteria that I'm aware of, except obviously if it continues to go into the red or things like that, then you're going to use your clinical judgment like you would typically to go ahead and stage that. I have used it for patients that I did not have baselines that were coming to me to be wrapped, like they already had chronic lymphedema. So sometimes what I've done too is go ahead and get a measurement before we start doing the complete decongestive therapy, because I know they're going to be in red, but let's say it was a 90, and then we did the complete decongestive therapy with the MLD and the wrapping, and then now they're down to a 60. So at least they get to see some objective changes that way too, visually with that. And then that's always a nice thing just to document from an insurance perspective too.
Thank you. So how do you bill for that?
How do I bill?
Yeah,
So
so what do you bill? What do you bill for the SOZO? I mean, it takes time, right? It
it
takes a very
does.
short time,
So
but
we
you
have
have to
it built
document.
in as bioimpedance.
Okay.
It's kind of a unique thing that is set up where if a patient wanted to come just for SOZO, there's a cash pay option. If it is built into their treatment and they are, actually getting the evaluation, the progress, and all of that, we bill their insurance. We appeal for that. It's a very complicated process, if I'm being honest. And then if it is not, then the patients are kind of known about that. And I guess I would say it's kind of written off on our end. It is a very complicated process. I'm not actually involved in that part of it. So
Well, thank you.
you're
So
welcome.
one of the questions is about an email that this particular clinician received about the PREVENT study, and that wearing compression prophylactically is preventative for breast cancer-related lymphedema. This particular person said that they learned the opposite. So this is definitely for all of you, but I personally, as a lymphedema therapist as well, I think any reduction in lymphatic burden is always a good indicator of preventing progression. If we can continue to reduce that lymphatic burden. And that's just my feeling, but let me know how all of you feel about that.
Oh, I agree. If we're just trying to support their lymphatic system, and similar to a lot of therapists and doctors will use compression stockings, not because they have lymphedema, but they want to prevent lymphedema. They want vein support. So just the same way that we would wear compression stockings to help to support our lymphatic system,
Right.
we don't have an issue yet. But if you have somebody who's had surgery or had lymph nodes removed, if they've had chemotherapy and they're at risk, having a compression sleeve, is a great thing to have that lymphatic support. That's my preference.
I always think too that, everyone has that lymphatic load, and oftentimes there's other comorbidities that are in addition to their cancer and their surgery. So diabetes, obesity. So to prevent it, support it, I absolutely agree. I'm not sure if Tara or Carrie have any input or anything additional to say about that.
I agree with Kaylee. I feel like why not have it to use? I don't want someone to be consumed by it. That's always the mental thing. If you've got to read how they're feeling mentally about things, because some people will take a little bit of information, run with it. And so I don't want them to be consumed by that. I want them to go live life, but I want to make sure that I've set them up with the appropriate tools for that and or the appropriate education that if something does come up, they then know where to come to get those services. And I just feel like that's an extra thing that they could have if they needed it. But I always want to make sure that they know this isn't something you have to do, but this does allow you to be proactive.
Yeah, that's exactly right. Thank you. There's a question in here around insurance, and it kind of brings me to one of the comments. I think it was Kaylee that said this, having to patients come back after a year for a quick follow-up or a check. And so does insurance typically cover that within the prehab or the surveillance or the follow-up visits? Where does the line stop for insurance coverage, and how do you get that paid, I guess?
So often we'll have them come in for another evaluation. So if it's been a whole year, we can't go under the same plan of care. So usually what we'll do is when they come in to see their doctor at their 6-month, 1-year follow-up, at that 1 year, we'll make the recommendation, hey, remind your doctor that you'll need a new prescription for therapy, and let's come in and let's get it checked. So at that point, we redo the evaluation. These are usually much faster evaluations. They're not as complex because we already know the patient's history and what's going on with them. So it's just billed as another initial evaluation. And after a year, there has not been any any question from insurance companies as to, whether or not that's needed, as long as we have the correct diagnosis codes, especially including breast cancer in this particular instance. I haven't had any issue with insurance denials for that.
So, and this is for any one of you as well, just that taking that leap in going to tumor board, taking time outside of work and doing volunteer work with maybe support groups or a cancer committee. What started the motivation to do that for you? What each of you, were you frustrated within your own programs? Were you wanting a program and it was just difficult to get it off the ground? And did you have colleagues that supported you and helped you? I would love to hear, how you get past that, because I think that is such a struggle.
Can you hear me now? Hopefully.
I can hear you, yes.
Okay. For me, it was working with so many women who said, why didn't I know this sooner? And me going to the physicians and saying, look, you have women who obviously needed this and they're hungry for it and they want better results after the fact. And so that was how I got invited in and slowly just started intervening and telling them, how therapy could help, how we could intervene, what we did, what we were about, that physical therapy wasn't just about walking, that, it's so much more. And so just slowly and steadily being persistent.
I was
Carrie?
just fortunate. I knew right off the bat that I wanted to go into oncology rehab. And so when I started working for this hospital, they knew that about me. I didn't hide that. And then there was just a position open in our cancer committee, and I volunteered for it. It's not an something I do as volunteer work, because I do get paid for it to be part of that committee, and have that representation from our department. So it's something I get to do. But then, yes, I continue, just like Tara, I continue to hear from patients. Why didn't I know about this sooner? I wish somebody had told me about this sooner. And so from there, it's some frustration. And if this person was my sister or my mother, I would want them to have gone to some education, some outreach, and to know that this option is out there. It's just, for me, it's just the right thing to do.
Right. Yeah, I love that. There is a question in here about the increasing number of patients that now do receive lymphatic surgery, right, prior to breast surgery. And so do any of you have any protocol that is different for these patients, or do you have the same protocol for patients that undergo lymphatic surgery prior to their breast surgery, or at the same time? Sometimes they do the arm, sometimes they do, lymph node transfer or the lymphatic venous anastomosis prior or at the same time of their breast surgery. Is there any difference in your protocol and your treatment plan, or even education, I guess?
We're trying to be more vigilant when they are having, when we're doing that chart review, we can see that plastic surgeon is also involved. And we found that early intervention, that reroute, that decreasing that stagnation is very important, because that lymphatic system has been disrupted too, those lymphatic vessels. So even more so being vigilant, I think, with those patients. They're on the same protocol, but just giving that extra eye and that extra education, and talking about those prophylactic sleeves and that compression pump and the maintenance options, I think are very, very important with that population.
I was going to say, I'm in Southern Indiana, so in our area, we're not seeing a lot of that done at the same time or prior to the surgery. It's definitely after the fact, when someone has already developed chronic lymphedema. So I would say our protocols are going to continue to evolve as we're seeing more of that, and hopefully more proactiveness. And just like Tara said, I think just continuing to be proactive and addressing things as we can to help these patients. But I'm glad to see more of that is being done sooner rather than later, because we're only getting them well after the fact, at least where I'm at.
Yeah, exactly. One of the things that came up and I was thinking about too is Tara had shared that data from her study, from her facility, and that was a pretty significant reduction in number of visits with the prehab versus not having the prehab. So I'm curious about your facilities and what results the two of you, Kaylee and Carrie, have seen from your prehab and your surveillance programs in your patient outcomes, and how is that being received by the center itself?
Well, I loved that data, Tara. I actually took a picture of it because I was like, ooh, I've got to share this, which I know it's recorded, but I was like, this is exactly the type of thing that we're trying to track, especially with the PM&R physician that I work closely with. So that was fabulous because we have looked, especially since we've had SOZO over the past 3 years, of tracking different things with outcomes, patient outcomes, all of that. Right now, our big thing is just tracking referrals. Like, how are our referrals increasing with adding SOZO? How many more patients are we able to help as our hospital system is expanding into even more rural communities? Like, how are we expanding our services to outreach people? Because we'll have people travel from, hour to 2 hours away just for our therapy services because there's no one around us that does that, and that can get taxing in itself. So that definitely gave me at least some ideas of where we can go. But right now, it's a lot of just tracking outcome scores is what we have been doing, and then the amount of referrals.
Okay.
I have a similar experience as Carrie. A lot of it has been tracking referrals, tracking outcomes, outcome measures, that sort of thing. But Tara's information is so exciting. I know our hospital will be creating new goals in December for 2025, and I'm excited to maybe present.
Yeah.
Incredible. And so if we can, as a community, replicate similar outcomes, I think that would just be such a strong study to be able to say, hey, nationwide, this is what we're getting. I think that would be incredible.
Yeah, absolutely. So we are past our time. There are a few questions, and I will ask the presenters to maybe answer a few of them via email if possible. But I think this was fantastic. It's so needed, and I appreciate you all coming on tonight and really giving us so much information about your programs and your outcomes. Thank you. And I want to just go on from here to also give you some information about upcoming programs. We do have a webinar that is new. It is a new continuing ed course, and it is fibrosis and lymphedema, and it is going to be Wednesday, November 13th. Please come and listen. It's going to be fantastic, as well as edema management in orthopedic care, which is also a continuing education course, and that will be Wednesday, December 4th. And you can certainly look here at the QR code and get more information about that. Thank you. I hope you all have a great night.